Okay.
Good morning. Welcome to our session on the Clinical Practice Guide Update. My name is Melissa LaChapelle and I'm a registered dietitian and provincial practice lead with Nutrition Services. I'm also the chair of the PEAS Standardized Practice and Education Working Group that authored the Clinical Practice Guide. The objective of today's session is to provide you with an overview of the updates to the PEAS Clinical Practice Guide. The Standardized Practice and Education Working Group performed a jurisdictional scan, as well as additional literature reviews. From there, updates were made to the sections for screening, diagnosing pediatric feeding disorder, facilitating safe swallowing, skill development, sensory processing, home blended feeding, tolerance, enteral nutrition administration and weaning, relational feeding, and the neurorelational framework. A new section was also added for surgical management. I would like to thank today's presenters for their contributions to the PEAS Clinical Practice Guide update. They are here today to represent the many clinicians that contributed to this work. Thank you, Julia Giesen, Patty Okrafka, Christina Van Nest, Carrie Failer, Dr. Caroline Hapshin, and Dr. Hamdi El Hakim for sharing your experience and integration of the PEAS Clinical Practice Guide into your practice. We have just a couple of housekeeping items. If you have comments during the presentation, we welcome you to write them in the chat box and select all panelists and attendees if you want to make your comments publicly visible. We will also have time for dialogue and questions around 11:20 a.m., and you can use the Q&A or raise your hand feature to ask any questions. We will wrap up the main session at 11:30 and then provide an additional 30 minutes to have a percolator time for participants to ask more questions and facilitate discussion with our presenters. We begin by acknowledging that our work is conducted on the territories of Treaty 6, 7, and 8 and the homeland of the Métis. We also acknowledge the many Indigenous communities that have been forged in urban centers across Alberta. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. The Pediatric Eating and Swallowing Project is a provincial quality improvement initiative with the purpose of developing a clinical pathway to standardize and improve the care of children with pediatric feeding disorder. This project has focused on care provision in the ambulatory care setting, such as outpatient clinics, home care, and community rehabilitation. The PEACE project has achieved so much over the past few years, and we are grateful that it is transitioning to operations in the coming months. We encourage you to visit the PEACE website at peas.ahs.ca. Here you will find a number of resources for families as well as providers. The Clinical Practice Guide updates have been posted in both a PDF and online format. You'll also find today's presentation recording posted after the session, along with the slides and speaker bios. We'll start our session today with a brief update on screening and diagnosing PFD. Children and families who identify a feeding concern should be screened for pediatric feeding disorder using the Feeding Matters Infant and Child Feeding Questionnaire. Parents and caregivers can complete the screen online and refer to the PEAS website to find services. Newly added to the PEAS Clinical Practice Guide is a condensed version of the questionnaire, comprised of 6 questions that can quickly identify and differentiate children 0 to 4 years of age who have pediatric feeding disorder from those who may have picky eating. We encourage you to take a look and see where you can use this tool in your practice by asking the questions, does your baby or child let you know when they are hungry? Do you think your baby or child eats enough? How many minutes does it usually take to feed your baby or child? Do you have to do anything special to help your baby or child eat? Does your baby or child let you know when they are full? And based on the questions above, do you have any concerns about your baby or child's feeding? These red flag answers are located in orange on the card, and if 2 or more of the answers are orange, we would like to refer on to additional services. We have also added the Parent-Reported Outcome Questionnaire for swallowing dysfunction in healthy infants and toddlers. This has been added to the recommended tools to screen for swallowing risk. Dr. El Hakim and Wendy Johansson were integral to this work and the publication. Did you know that May is Pediatric Feeding Disorder Awareness Month? It is estimated that 1 in 37 children have pediatric feeding disorder. The diagnostic term pediatric feeding disorder is a recognized US ICD-10 code. This diagnostic term was added to the Alberta Health Services Provincial Clinical Informatics System Connect Care. Diagnosing requires the healthcare provider to identify and label the condition that they are responsible for treating. Accurate and consistent application of diagnostic codes yields valid and reliable data on health utilization, costs, quality improvement, and research outcomes. The benefits of using the PFD diagnostic term include consistent messaging for parents and families, an increased awareness and consistent identification of children with PFD, and a better understanding of conditions associated with PFD across health domains. It also allows us to accurately calculate prevalence data in Alberta and to refer to the appropriate healthcare professionals. An infographic has been published to the PEAS website to help raise awareness amongst healthcare providers to call it PFD and support Albertans.
Hi everyone, I'm Julia Giesen and I'll be speaking to Section 8, Management of Oral Feeding, specifically the sections on facilitating safe swallowing and feeding skill development. A big shout out here to Melissa LaChapelle, Beverly Collison, and Amanda Adset for their contributions. This section underwent a good deal of reorganization, beginning with the goal of dysphagia management to facilitate oral intake while minimizing the risk of airway compromise. The nature of dysphagia as multifaceted was emphasized, recognizing the medical, surgical, skill, and nutritional contributions. It was further emphasized that a multidisciplinary team is best practice in order to manage these multifaceted aspects of dysphagia, and focusing on feeding and swallowing as neurodevelopmental skills. Management of dysphagia requires individualized care based on the etiology of the dysphagia. Strategies to manage dysphagia can include compensatory strategies, such as altering the pace, texture, equipment, or presentation of foods. Rehabilitative, which it works to improve the oropharyngeal physiology, or habilitation, the development or maintenance of skills. In Section 8.2, we developed a new section on pill swallowing, taking into consideration the neurodevelopmental readiness and display of skills required by pediatric populations in preparation for swallowing pills. We also updated modifications to medication, recognizing that the mode of delivery is important in this population. Section 8.5 on feeding skill development also underwent an upgrade. In this section, we emphasize the importance of considering the neurodevelopmental stage of each patient, the importance of early, timely, individualized assessment and ongoing intervention to address feeding skills, the essential nature of collaborative goal setting involving parents from the very beginning to establish functional, meaningful goals, and to help them to build a responsive feeding relationship that can sustain the child throughout their feeding development. The principles of motor learning were applied to oral feeding skill development in Section 8.5, emphasizing the importance of developmental progression, consistency and repetition, selecting functional motivating tasks that facilitate speed and endurance in feeding, ensuring we are simplifying tasks and providing the specific support required to have success, while tapering support and increasing contexts and environments as those skills develop, continually reassessing to upgrade goals and reduce supports while maintaining safety. A new section in 8.5 feeding skill includes considerations for soother use. Here we did a deep dive into the literature to look at the benefits and the risks of soother use. Benefits including the development of non-nutritive sucking and regulation, self-regulation for infants, and the risks of long-term use. We also built in considerations for feeding at breast, bottle, and with progression to solids.
I would like to take this opportunity to thank Julia Giesen for not only her contributions to the PEAS Clinical Practice Guide, but also for chairing a subgroup that developed numerous patient and family handouts. I'll now welcome Patty Okrafka, an occupational therapist and senior practice consultant with the Provincial Rehabilitation Team, to speak to us about the updates to the sensory processing section of the Clinical Practice Guide.
Thank you. I'm really excited to share with you the updates that were done to the sensory section of the PEAS Clinical Practice Guide. So this section was updated with an emphasis on evidence-informed best practice, and it reflects a shift in practice towards function-focused intervention. So the sensory section of the PEAS Clinical Practice Guide went through a full content review and an update by an interdisciplinary team. Sensory processing in general was looked at this year within AHS, and that resulted in the development of a provincial standardized approach and a provincial practice guide for sensory generally, which for AHS staff can be found on Insight. And so what we wanted to do with the sensory section of the PEAS Clinical Practice Guide was that we wanted to ensure alignment with these core provincial documents and of course with current evidence-informed best practice. And so the new sensory section of the PEAS Clinical Practice Guide reflects the literature and points us towards functional interventions. And not just, it fits beautifully with the application of sensory within that functional task of eating, feeding, and swallowing. So this section reviews some of the theory, the literature, the key intervention programs that apply sensory practice to the realm of eating, feeding, and swallowing. The revisions highlight an emphasis on interdisciplinary collaboration. They also emphasize holistic assessment involving consideration of the child and their skill, the eating, feeding, swallowing task, as well as that sensory environment. And lastly, the revisions also reinforce the need for outcome measurement to ensure efficacy of any sensory-related intervention within eating, feeding, and swallowing. So exciting updates with lots of references for further reading if anyone is really interested in more information on this area of practice within eating, feeding, and swallowing. Thank you.
Thank you, Patty, for leading this work and the updates to the sensory processing section of our guide. I would now like to welcome Christina Van Ness, who is a dietitian at the Alberta Children's Hospital. She'll be speaking to us on home blended food for tube feeding and assessing tube feed tolerance.
Hi everyone, I'm here today to introduce a new addition to the CPG, home blended food for tube feeding. Home blended food for tube feeding can be defined as whole foods and liquids blended into a fine puree or liquid that is administered through an enteral tube. This is important to include in the CPG as there is new research emerging every day on the benefits of whole foods for tube feeding. And we see this in the number of families in our clinics requesting support in adding whole foods to the children's feeds. The CPG outlines when to consider home blended feed. Some of the considerations are medical stability, absence of malnutrition, having a mature stoma, and an adequate tube size. In addition, tolerance to bolus feeding, ability to tolerate variable nutrients, electrolyte and fluid intake. And then, of course, the family's ability to prepare food and blend for the tube feed. Although there are many advantages to using home blended food, there's some considerations for home as well. It can initially have some increased startup cost, purchasing the high power blender, and the change from formula coverage to planning for food costs. Increased preparation time compared to commercial formula can be a little more inconvenient, shorter administration time due to food safety. Blended food can get stuck in the tube if it's not prepared properly. There can be issues with volume, tolerance, and meeting nutritional needs. So it's important to evaluate these considerations before determining if this is a good choice for your patient or child. Due to the benefits of home blended feed being an increased thickness, improving reflux and vomiting symptoms, it's best administered as a bolus feed using a syringe to maintain the thickness. Less viscous blends may be administered by gravity large bore feeding sets, but can be prone to clogging if the blending is inadequate or there is sediment. One of the new additions is that children unable to tolerate syringe or gravity bolus feeds may have improved volume tolerance using a pump. There has been a table created for feeding pump selection and pump criteria using the International Dysphagia Diet Standardization Initiative. Home blended feeds can be tested for thickness, and that will help determine if a pump may be appropriate for administration. In addition, not in the CPG, but as part of the emerging need for resources in this area, Carrie and I have received support from the Peace Project and Nutrition Services, as well as other AHS partners, to develop a series of videos intended to support families in providing home blended food for tube-fed children that will hopefully be launched later this year. Another addition to the CPG is the flowchart to help assess the reasons for intolerance of enteral feeds. Common symptoms of intolerance can be nausea, vomiting, diarrhea, constipation, abdominal pain, and abdominal distension. Often formula is unnecessarily changed without the source of the intolerance being identified first. If a patient is well established on an enteral tube feeding product, it is rare to develop an intolerance to the product itself. It is important to identify the underlying cause for intolerance before changing formulas. Assessing tube feeding tolerance consists of reviewing the enteral feed plan, including the rates, the volumes, and the schedule, and then exploring other causes for the symptoms. For example, if the child has abdominal pain, cramping, and is retching or vomiting, are they constipated? You may want to assess bowel routines, bowel frequency, activity level, hydration. Often small adjustments in rate, volume, and schedule can improve tolerance. However, if intolerance continues, the flowchart gives you ideas of other causes to consider or assess further.
Thank you, Christina, for giving us an overview of home blended food for tube feeding considerations and identifying for us the importance of assessing tube feed tolerance. I will now welcome Carrie Failer, dietitian at the Stollery Children's Hospital Home Nutrition Support Program, to speak to us about enteral nutrition administration and tube weaning.
Hi everyone, I'm going to highlight some of the new updates in the CPG guideline with respect to enteral nutrition administration and tube weaning. An important part of enteral nutrition administration is the hang time, otherwise known as safe administration at room temperature. New in the CPG guidelines is the hang time chart. Of special note, the home blended foods are safe at room temperature for up to 2 hours, both in the hospital and at home, and therefore best for use with syringe or large bore gravity feeding. The ready-to-use blenderized formula, such as Nestle Organic Blends or Functional Foods Nourish, can be used at room temperature for up to 8 hours in the hospital and 12 hours in the home, depending on the manufacturer instructions. It is important to note that bacterial contamination is different in the hospital and home environments. Safe extended hang times for ready-to-use formula of up to 8 to 12 hours can be achieved by reinforcement of proper hand washing, preparing feeds in a clean area, minimizing unnecessary feed handling, and proper storage of breast milk, formula, and any additives. Also important to consider in the administration are fat and energy loss that may occur in relation to the feeding set material interacting with the feed type, specifically higher fat containing feed types and the length of time required to administer the feed. The highest fat loss occurs in the first 30 minutes of administration. However, fat loss will continue to increase with longer administration times. In these cases, and if well tolerated, syringe feeding may work best. Enteral feeding is a potential source of infection due to the risk of bacterial contamination of feed products and enteral feeding equipment. It may occur as part of the feed preparation, administration, or with retrograde bacterial growth migrating from the feeding tube into the delivery set over time. There is limited evidence on the safety and clinical outcomes of cleaning and reusing enteral feeding equipment in the home setting. It is uncertain whether enteral feeding equipment reuse of up to 72 hours leads to an increase in adverse gastrointestinal symptoms or gastrostomy site infection. At this time, the Alberta Home Enteral Nutrition Support Programs recommend that any enteral feeding equipment that is reused should be sufficiently cleaned to reduce the risk of bacterial contamination of subsequent feeds used at home. Feeding pumps should be cleaned and serviced regularly. Feeding equipment such as syringes, feeding sets, adapters, and tube extensions should be cleaned using warm soapy water and then rinsed well. The approaches used to develop tube weaning programs, regardless of whether this is based in the hospital or home, can be characterized by three approaches. A behavioral approach focuses on the psychological aspect of feeding and unlearning the association between food, caregiver, and trauma. Conditioning tools are used by feeding therapists, and caregivers are brought into therapy when aversive behaviors are unlearned. A child and family-centered approach focuses on the parent-child relationship, combining developmental, biological, and therapeutic aspects of feeding. Appetite manipulation is started early in the intervention to help the child learn feelings of hunger and regulation. A biomedical approach focuses on eating as a biological process, combining intensive hunger provocation with a behavioral approach. The biomedical approach is often used in inpatient intensive weaning programs, may include medication, and requires close medical monitoring. Any successful tube weaning model should be tailored to the child, involve an interdisciplinary team, and utilize a combination of these approaches, and is often characterized by the child's readiness for oral feeding, such as safe swallow and oral sensory motor skills, a positive feeding relationship, normalization of feeding and eating behaviors, and the use of behavioral technique to increase oral intake. Recently, a provincial model for tube weaning has been developed and is currently being piloted here in Calgary, Alberta. This will soon be in use provincially for all healthcare providers and patients to access.
Thanks, Carrie, for that overview on enteral nutrition administration, cleaning, and tube weaning. I can't wait to hear more about the Calgary program and their results on their tube weaning model. I will now welcome Dr. Caroline Hapshin to talk to us about relational feeding and the neurorelational framework and those updates that were applied to the clinical practice guide.
Hello, good morning, everyone. I am updating today on relational feeding. You can see on the slide here which sections were updated. These were relatively small tweaks for this revision, but we did work hard on improving the language, so it was really clear that relationships matter and the importance of the caregiver being responsive in monitoring their behavior and how they are with the child, as well as the child's responses. So these are the sections where we updated this information. Next slide. So I'm going to today give an overview of relational and responsive feeding and give you some information from the neurorelational framework. You will see in the guide in these sections that there are many quotes referring to the neurorelational framework. So I thought I'd just give you some more information about that. And then briefly, we'll talk about when to engage mental health or psychology, and then I will leave you with a few resources. Next slide. So throughout the guide, we've emphasized that feeding is a relational and responsive process. So what this means is that when adults are engaging with children of any age, they need to be supporting serve and return. So that's that nonverbal and verbal reciprocity in the interaction, and ideally that it is positive and supportive to the child. The adult is sending cues to the child, as well as the child sending cues to the adult, and vice versa, with cue reading. So this is important, I think, for all clinicians to be aware of. And when we are working with children and caregivers, that we are monitoring this back and forth serve and return and supporting the optimal quality, I guess, and as well positive interactions. And this is important because the child develops self-regulation in the context of the caregiver providing co-regulation. So we tell our families that they need to be in a calm, alert, processing state to support their child's calm, alert processing state. So then that's where learning happens. And that's where we get the best capacity, I guess, of the child to develop those eating skills. In the guide, we also have reference to responsive feeding therapy, which basically is describing what I've just reviewed there. This idea that the adult is responsive throughout the child's attempts at eating. Next slide. So, as I've mentioned, there are references to the neurorelational framework in the CPG, and the reason for this is that it supports many of the concepts that we're trying to encourage practitioners to learn. And so what I thought I would do this morning is just highlight a few of those concepts that were referred to in the CPG. Next slide. So in the CPG, we talk about safety, challenge, and threat. And so this graphic and the three graphics I'm going to show you are not in the CPG because they are part of the neurorelational framework, but they are able to be accessed for free, and I'll give you that reference. And we're finding them very useful to use to teach families and to support the way that we can explain it as clinicians. So it's important that feeding occur while there is relational safety. And so this is where that serve and return is happening and positive engagement is being supported. The adult is connecting and co-regulating the child, understanding the child's needs moment by moment, and then monitoring for the child experiencing challenge and introducing an appropriate, just right challenge for the child, matching neurodevelopment, and then tweaking as needed, and then reducing demands if necessary so that the child is not overwhelmed by the challenge of eating. And this goes back and forth, this idea of introducing appropriate challenge and then backing off to relational safety. If we don't monitor this, then we can induce a situation where the child is feeling threatened and experiencing intense stress responses. Next slide. So we work with families and teach them about states of arousal, what happens in our autonomic nervous system when we experience challenge or threat. And we use this graphic to describe these states of arousal. And so I've mentioned that we learn best and eat best in a calm, alert state. And shorthand for this is the green zone. When we are in the green zone, the gas and brake, or the parasympathetic and sympathetic aspects of our autonomic nervous system are in a nice ebb and flow and balance, just right for the task. But when we get stressed, we may have the gas pedal go on in our nervous system, and children may become goofy, silly, hyper, busy, fidgety in the chair. That's the positive red zone. The negative red zone is where children will get irritable, angry, may refuse while eating. And if we push, they may have a full-on meltdown. The reverse side is the blue zone, where children become passive, disengaged, withdrawn, may look sad, may glaze over and actually dissociate in extreme situations. That's the parasympathetic side of the nervous system. And then we have a state of arousal we call the combo zone. This is where we have co-activation of the brake and gas. This is where we feel jittery, we feel anxiety, fear, and in extreme situations, panic. And of course, these states of arousal are supported by optimal sleep, quality and quantity of sleep. So this is what we need to monitor as clinicians while we're supporting eating, and help the parent understand their stress reactivity, how they are in the moment, and how the child is in the moment. I think this is essential when we're doing any kind of feeding intervention. And I think all practitioners can learn this, learn to observe that parent-child interaction and observe these states of arousal. Next slide. In the CPG, we also talk about toxic stress. We refer to the Harvard Center on the Developing Child, information about toxic stress, but also to the neurorelational frameworks, definition of toxic stress patterns. And again, important to monitor during any kind of eating situation, whether the child is stressed and are they having too frequent, too quick, too intense stress responses. If they are not recovering, then we need to back off and again, go back to that co-regulation and relational safety. Many children have challenges adjusting to transitions throughout an eating episode or to and from eating. And then if children are not in the green zone, then trying to teach them how to eat is basically not going to work well. And we may contribute to trauma. Next slide. So that was a whirlwind tour of a few of those neurorelational framework concepts that are in the CPG, and I'm giving you these extensions so that you can explore it in more detail. So the other question I was assigned to answer is this: when do we engage psychology or mental health services as practitioners? Well, here's a few ideas. And again, when children have experienced trauma with eating, or they are suffering from any kind of emotional or mental health symptoms that are affecting function, then I think it's important to engage mental health. And then same for the parent. So how do we engage mental health services? I mean, it should be pretty straightforward that if a child is suffering and a parent is suffering psychologically, that we engage mental health. The problem in our systems of care right now is that many mental health practitioners do not have skills specifically with regard to supporting eating. And so we are working on this challenge. We are making good progress within Alberta Health Services in engaging mental health in this process. And I am excited that we have the CPG, because I think that will really help my colleagues in mental health understand the work that we need to do. And we're going to get more collaboration. That's the long-term goal. For very young children, we do have services available at Elm Tree Clinic. We have child psychiatrists that have expertise in eating, but unfortunately, that's just for kids under 3.5. For our older children, we really need to do some significant work on continuing education. Next slide. So here's some resources. I'm extremely excited about the Getting Through Mealtime Struggles videos. I think Liz Matthews and her team did a great job of putting this together, and some of those neurorelational framework concepts are included. And I've given you some other references here as well, just to expand your learning. And just another word, infomercial, as Alberta Health Services is working on continuing education opportunities for allied health for the NRF. More to come. And I'm all done.
Thank you so much, Dr. Hapshin, for sharing those resources with us. We've definitely added a few things to the CPG and have more to come, so thank you. I will now pass it over to Dr. Hamdi El Hakim to talk to us about surgical management. So I will stop sharing. Thank you.
Sorry, I had to I had to unmute myself first. Good morning, and thank you very much for having me over here. I've learned a lot, and I think we are in a fantastic place in the province, courtesy of this program and all the efforts. I am not the jack of all trades that does all of these tricks, surgical tricks, but I can speak to some of them. I have no conflict of interest except some bias that are harmless to the little kitties and to coffee. I would like to rush you a little bit through some of the bleeding obvious explanations to feeding and swallowing problems, concentrating more on swallowing. And I want to show you how can I help along with the team that works in the aerodigestive clinic. Now, tongue ties are as famous as rice and bread, but the problem is people got fed up with them because everybody wants to clip them for a variety of reasons. And a consensus statement came from the American Academy saying they can be a problem with breastfeeding. They can contribute to maternal pain in poor infants, but they're not really the only thing. And there are steps to be taken into breastfeeding clinics before clipping and diving into the little tongues. On the same time, there are, again, going by the bleeding obvious, big problems. Some of them relate to babies who cannot really leave and go home from intensive care units, like Pierre Robin. And times has changed, and we came far away from nasopharyngeal tubes that you see on the baby on the right-hand side, and now we can expand their mandibles and push them through. But lo and behold, as successful as this method is for airway obstruction, the evidence on improved actual oral and safe feeding is very sparse, incredibly sparse. People do not care about documenting this with instrumental testing. And so the usual information is if they are not syndromic, they're going to do fine. They're going to have some oral feeding, but we do not know how much, what consistency, and over what sort of period of time. And we have also, amongst the bleeding obvious, our friends from tracheoesophageal fistulas. Terrible combination, a hole between the airway and the esophagus. You can't really live with that. So our general surgeons, talented enough, they fix all of this. But we in ENT see a little bit of few problems like laryngeal paralysis, subglottic stenosis, residual tracheomalacia, and these kids have problems with breathing. And if you have problems with breathing, you can't swallow properly because you're panting all the time, you're struggling all the time. And definitely, again, after we know that the esophagus is somehow patent, we don't really test always for safety of swallow again. And don't forget us, we basically deal with that along with the remaining esophageal problem. The term swallowing dysfunction is a bit of a debate, and splitting definitely swallowing from feeding is good for people, although there is definitely overlap, as you all know. But it's all about food and drink not going into the airway, because that is not good for anybody, adults or children. You end up seeing somebody like that little bunny who basically is like an engine, really, bless him. Children were told not to be seen or heard, but really it's feeding that should not be heard that loudly. And if you come to a little guy like this with low set ears and a small jaw, you can actually kind of, poke and say, well, does he have problems, and maybe he can fall into our hands. The aerodigestive program has been set 10 years ago. Bless her soul, Wendy Johansson is the real player and founder. And we basically drain or receive the referrals and triage them between pediatric otolaryngology, myself and Dr. Isaac, and speech and language pathology, Minnie Kurian and Amanda Atzet, and we decide who the risk. And the first tier is to go to the aspiration clinic, where we meet the family and assess, and where necessary, we channel into the other level where respirology and gastroenterology are there with us. And we do a structured clinical and history, and we basically see if modification of diet and peaceful measures are working, and if they're not working, we dig a little bit deeper into the black box and see where we go from there. The standard study that will remain a gold standard assessment, it shows you in as natural a position as possible and less intrusion where the bolus is going, but there is a price. The price is a dose of radiation that varies from one center to another. Through it, sometimes you also see little holdups like the upper esophagus here that has that little bar that basically can be tackled by dilation or by injection of Botox, and sometimes with surgical division. We can also see funny things during normal barium swallows, like this aberrant subclavian. But FEES is our bread and butter kind of, and our staple instrument. Parents get explained quite nicely. These are the hands of Wendy Johansson. The little guy is fed, and I basically go and, excuse me, sir, find the camera, go through the whole thing, and we have another monitor for the parent to have a look at it, and it shows me a nice view of the larynx altogether. Interesting thing is our first 140 patients who are not neurologically impaired had that array of airway abnormalities. So the overlap is quite obvious between swallowing issues and airway problems, and you can't really tell ahead of time. I know that the classic textbooks talk about, biphasic and monophasic and whatever, stridor is like. Life is not like that. And with us playing big deal with big neurosurgical activities and cardiac centers, we see a lot of unilateral laryngeal paralysis, courtesy of some interventions. And these guys end up not being able to protect their lower airway. And we basically can help a little bit. We can push that vocal cord medially a little bit, either by an injection or by a piece of plastic. These are actually less numbers than one would think, because compensation happens quite nicely, but with the caveat that long-term follow-up for these patients is very few and far between. With the addition of my colleague, Dr. Isaac, we also have a talented surgeon who can actually hook up or hitchhike a sort of less useful nerve like the ansa cervicalis to go and replace the left recurrent laryngeal nerve. The results are promising. They definitely are so for voice. There's some accumulating evidence, but we don't have enough for feeding and swallowing safety. And then we hear about the laryngeal cleft, or what I usually like to call Loch Ness Monster, because not everybody has seen Loch Ness Monster. You basically have an easy task in order to identify deeper laryngeal clefts that go through the cricoid or through the trachea, like the panel on the left-hand side lower. But the upper one is showing the subtle type 1 cleft. And I actually do not wait entirely in order to see anatomically that way. When we basically look at the functional endoscopic evaluation of swallowing, on the left-hand side, there's normal appearance. You barely see the dye and its color. On the right-hand side, once it slows down a little bit, you'll see the premature spill, and then you will see the leak going posteriorly, right where you would think a laryngeal cleft is. Laryngeal clefts cannot be diagnosed with flexible endoscopy. It needs a suspension laryngoscopy and a magnification of 6 times. What can you do, Hamdi, for it? We can basically inject it, or we can repair it surgically with a few sutures. And I hope that these videos work. The whole idea is to augment the area in between the two arytenoids. The procedure on the left takes about maybe a minute or so, and the procedure on the right takes about maybe 20 minutes. And we have our own signature, so to speak, technique, which I put together, and I trained several surgeons in the States and in Saudi Arabia to do it. It's much less invasive than what most of the American centers do, and it's about maybe 80% successful. This is gaining traction after a huge length of time of skepticism by the societies, and we're making definitely headway. I work a little bit faster than the video, don't worry, I had to slow it down for you, tongue in cheek. And then finally, laryngomalacia is everybody's noisy little child, but you know what? There's a bit of caveat with this, but there's no doubt that half of the patients presenting with laryngomalacia have a swallowing issue. And this has come together after instigating looks into it, and supraglottoplasty is a straightforward procedure that can actually help the child breathe better, and at the same time organize the suck, swallow, and breathe, and prevent aspiration. I sometimes combine it either with a laryngeal cleft repair. There are a couple of techniques, to do so, at least. They don't take a long time. Choosing the right patient, the right circumstances, they're home the next day. And again, nothing is 100%, but there are many children who basically end up losing thickening or losing the chance or the risk of getting onto a tube feed. I definitely want to send the message home that problems of airway and swallowing overlap a lot. There are many types of dysphagia that can cluster under the same umbrella. So your vectoral patient and your 22q11 deletion, your Pierre-Robin are not all about the one bleeding obvious spot. This is not a one-man show, one person's show. This is a multidisciplinary approach, and we will never all forget what Wendy has done. She has taught me a lot, and she set the foundation for this program. I take my hat off to her memory and to my colleagues. And thank you. I hope that I didn't go over the time.
That was excellent. Thank you, Dr. El-Hakim, for sharing the importance of considering surgical management as part of our management strategies for pediatric feeding disorder and dysphagia. We will now move to the question and answer portion of our session. So I'm just going to share my screen again. And I encourage you to put your questions into the Q&A box. We've got all of our speakers here available to speak to the different updates that they provided today. So we definitely welcome your questions.
I'm happy to be moderating the chat. I'll be looking both at the chat and the Q&A. At this time, I don't see any questions in either. You can certainly put them in and we'll respond to them as we go. I do just want to really congratulate Dr. El-Hakim on his use of a good metaphor for our session today when he said he was speaking tongue-in-cheek. I think we all can do that as we go about our work in eating and swallowing. So very apropos. I have a question, if I can start things off, to Dr. El-Hakim specifically. What is the current technique for doing tongue tie release for newborns at this point in time?
Honestly, there is no rocket science in that. I just basically take a pair of scissors and cut it. I've never needed to do Z-plasties or anything from what people describe. It's a simple, quick surgery. Just as an FYI, very silly mistake happens sometimes. The injection, well, the infiltration anesthesia can leak a little bit. And if it leaks, and it numbs the tongue, the child wakes up chewing their tongue. I never belittle any procedure, even if I'm going to trim the nails of the child inside the operating room under anesthetic. I tell the parents, think long and hard before you write down your little thing. Okay?
Thank you.
I would like to have a follow-up question about tongue tie clips and frenulum clips. I know it's been done in the community as well by dentists. Do you have any comment about, the need for it? Are we overdoing this procedure? Are there guidelines? Can you just give us a little quick update on that?
Honestly, I'm glad you asked that question. It's definitely going like wildfire, particularly recently. And hence, I think Dr. Hapshin, that when you see a consensus statement, then there is no evidence. And when there is no evidence, you get the few wise men and women and sit them together. And what they came up with is, yes, it can cause breastfeeding problems, but amongst other reasons. And you have to go through the right sequence. When you talk also in the same basket about lip ties, oh my goodness, what a load of nonsense. And the second indication for it, which really bothers me, is speech problems and preemptive stuff. And in the old kind of, way of looking at it, I do not want my child to be fork-tongued. And it starts to become really kind of, beyond the pale. So are there problems in practice? I would say yes. And I mean, we have a bit of an overlap with all medical specialties, no doubt about that, but I think the time has come for people to understand about swallowing a little bit more. I'll add just a little bit. I have heard on the BBC a podcast called Dysphagia, and I encourage you all to listen to it. It was all about adults, and I basically got I haunted them until they interviewed me, and we talked about children, and it was really, people came out of the woodwork with talking about their troubles and all sorts of things. Thank you for asking.
Weird coincidence. I was driving in my car and I actually heard you. I heard you and I thought, holy cow, it's Dr. Al Hakim. So that was a really weird coincidence. But I agree. I'll support your advertisement of that BBC podcast. It was very good, very, very good. Case studies and descriptions of what people have gone through. So one more question about the tongue ties, because there's lots of descriptions in the community about the challenge of the tongue not moving freely, and then we have troubles with development of the jaw, and the maxilla and mandible, and then sleep apnea and all the sequelae. So can you guys comment on that?
Sleep apnea is zero, and I mean zero. I'm a bit guilty to a limit. We've set up shop 10 years ago, myself and the orthodontist and respirology. And it was all about the relationship between the developmental malocclusion and airway. So we're talking about children who do not have syndromes, who do not have maxillofacial problems. And there's no doubt that it's an interesting area, but it seems that it caught up, and sleep apnea has become the business of those who do not have any business to do. And I was invited, unfortunately, to a forum, which I'm not going to mention its name, and I found people who are outside the medical field who are talking sleep apnea and prescribing CPAPs. And my heart bled really to be over there and listen to that kind of thing. I think they're taking things a little bit too far.
Thank you for your questions, Carol-Ann. I don't see any other questions right now, but I will pose another. This may be specifically for Carrie and Christina. Can you tell us about the maybe experience of families who have used the home blends for tube feeding, and some of the successes they've had, or some of the things that they would pass on to you as professionals in terms of their experience using home blends for tube feeding?
Hi, it's Christina. I'll make some comments and then Carrie can add if she'd like. I guess one of the big successes that we see with home blend is the impact on reflux. And we do see this with the thicker feeds. The other comment I would make is that my experience has been that we've been able to move a lot of patients off of the amino acid and peptimin, like the peptide and amino acid formulas, when they've been able to go on whole foods. And I think that's just the elimination of maybe those allergens or intolerances that they're able to do by choosing their own foods to blend. Carrie, do you?
Yeah, I absolutely agree with that, Christina. And I was going to say too that even when we add just 50% home blend to some formulas, that has made a big difference for families. So yeah, it's been great. Home blends is always beneficial, whether it's a small amount or partial combination too. So yeah.
Thank you both for answering. Melissa, do you want to wrap it up for us here? Although we will then stay on for more discussion around the water cooler.
Absolutely. So we will continue the question and answer period with our speakers, but do just want to remind you and encourage you to complete our brief survey. It'll only take you a minute or two just to let us know how we're doing and what kind of future education opportunities people might be interested in relating to eating, feeding, and swallowing. So the link is available, and I believe we'll put it in the chat box for you. So I encourage you to complete that. And we do have a couple extra questions, one which was answered by Carrie, so thank you for that. The question was around fat and energy loss, and home blended tube feeds refers to fat sticking to the tube and so does not actually get administered to the child. And yes, that is correct, especially for the higher fat formulas. So for example, ketogenic formulas are extremely high in fat. And then as well, there's evidence for higher fat breast milk residue staying in the tube or sticking to like the plastics of the bags and admin sets, depending on how that child's being fed. So there is comment on that in the clinical practice guide. We did get another question that from a dietitian that sees a lot of kids with picky eating, and they also have ADHD. And so the question is there any causation? As far as the clinical practice guide goes, we haven't done specific literature searches targeting specific conditions or diagnoses. So I'm not sure that we can comment on causation, but wondering if any of the clinicians or presenter clinicians on the call would like to comment on what they see in their practice.
I'm happy to chime in on
Thank you.
one. So bottom line is, over my years of practice, basically many children with many different mental health and developmental diagnoses, and the combination thereof have eating challenges of many varieties, including picky eating. And then there is also a huge overlap with sensory processing modulation challenges. So I would say there's not direct causation, but there is complexity for all our children that have developmental mental health challenges. Kids that have complex brain development function challenges have challenges with eating too. So I think that would be the short answer. Kids that are ADHD are often in the positive red zone. They are hyper, they are busy, they are fidgety. They don't have their executive functioning is challenged. So the challenges for sitting, focusing, eating, organizing themselves at the table are there. And that doesn't help with having them explore food, be curious, take their time, try food over and over again. I mean, their executive functioning challenges can interfere with that, in addition to probably underlying other challenges. So there's the short answer for that one. It's complex, and I think that's why at all our COPs, I will be there representing mental health and can answer those kinds of questions as they come up for all the topics of the COPs we're having this year. Because I think there's always, this is going to be common, this overlap.
And I must admit that your words resonate really, really well with our practices over here. As a general rule, I like to say better interfere and investigate children very early with suspected feeding and swallowing problems before things get really complicated and you don't know which basically is the chicken and which is the egg. We also have the cohort or the group of children who are the tracheostomy clinic members. Old dictum is essentially G-tube and basically put them almost NPO, and we lose a huge window of time, and many of those children have been diagnosed with ADHD afterwards or autism, and then it's oral feeding despite everything being intact, and in theory the process of oropharyngeal swallow is fine. It's just an absolute battle. I would love somebody working with us in the aerodigestive program of this. I really would love to see that.
I see a related question in the Q&A. For those kids, and I think this person is referencing specifically those with ADHD or perhaps other behavioral issues, can allergens also be an issue that should be ruled out? Maybe Carol Ann, I'll give you first go at that question.
So the question is with regard to picky eating, and that possibly is it allergens? I mean, could they be allergic or have food sensitivities? Parents often come up with that, is that there's concerns that their kids are refusing certain foods because it doesn't agree with them, right? Either because they're allergic to it or sensitive. Especially with kids that have really complex developmental challenges. This is very common for parents to find this information online and worry about it. Yeah, so I don't think that we have really good data on that though. If anyone else knows, I don't think so. I think it's, again, really complex.
As a pediatrician myself, I guess I would estimate that there are more people concerned about that than there are actually patients suffering from said allergies.
Exactly.
It does tend to be something that people reach for. Many times friendly neighbors, relatives, family members will make those suggestions. There's a lot of anecdotes that are shared around. And so sometimes it becomes a bit of mythology. So not to dismiss when there are genuine allergies, and for some people that is a very real and challenging phenomenon to deal with. But my sense is there is more concern about that than actually plays out in reality.
So I really encourage families to have their child to do it like an N of 1 study, so that they have to do it in a scientific way as possible. If they think that there's a food that's bothering the child, then if they're going to remove it, that they do, or a food group, like if they're going to go gluten-free or casein-free or lactose-free or whatever they're going to try, but they do it in a thoughtful way, and that they actually truly observe if there's any difference for 2 or 3 months, short period of time. And then if there's no difference, that they have to actually acknowledge that there's no difference. And what are they actually looking for? What change are they looking for? Is it, the consistency of bowel movements? Is it, willingness to eat? What is specifically are they looking for a change? And if it's symptoms like, well, autism is better, well, we have to I try and get them to narrow it down, as to what they're actually looking for an improvement, what is going to be better. And I think that has helped some families over the years, that they're more scientific about it. And then I also go through the whole discussion of how much trouble is this worth for them, the child, and the whole family, because some of this is really, really hard to do. Yeah, and oftentimes when we review, are there any gastrointestinal symptoms related to this food? There are none. Or are there actually signs of allergies? They're often not. So yeah, anyway, it's again back to another complex issue.
Mm-hmm.
I would caution as well that there are some professions where diagnosing food allergies is a common part of their practice. And I would say that in my perspective, my experience, sometimes those have not played out in the same way as how I would diagnose or describe allergy.
Yeah, and I would say from the dietitian perspective, where we want to see those kids that may have food allergies, to also help families identify what that child can eat, and looking at expanding that repertoire versus focusing purely on restriction, so that we can either prevent or mitigate or support a pediatric feeding disorder in that population.
There is a further comment, I think a rather astute comment being made as well in the Q&A, that it's noteworthy that kids with picky eating may be a manifestation of eosinophilic esophagitis. If the child does have asthma, hay fever, eczema, etc., then they would be at risk. So point is well taken there, that a concern about allergy or a concern related to these symptoms should be certainly evaluated by somebody with expertise in this area, such as a family physician or a pediatrician, to evaluate those things. Absolutely.
And I agree with Dr. Prasad's comment there. It's the kid. It's not just one thing that you see. Parents need to be guided towards giving a full description of what the child's challenges are. And we need to have, back to the whole team, evaluating, not just any of us going rogue.
We also had a question just regarding access to the Occupational Therapy Pediatric Clinical Practice Guide for Sensory Processing. And so Patty's going to look into that and see how we can share that beyond our AHS community, which currently can access it through Insight. So thank you for that question and follow-up, Patty.
Not seeing other questions right now, but we're certainly open to discussing more.
I just wanted to make a comment about the blended food for tube feeding. The families that I've seen where they've been doing this, I think there's 2 extra, and I'm not sure if it's included in the CPG. I haven't looked at that section yet, but the burps of the food and the taste of the food, I think, is really important for the child and for the parents who have been doing this over the years. It's super important for the parent to prepare food that their child is eating, and that I think psychologically for the parent, that they're not just giving the kid formula, that they're actually preparing food, is really important as well.
Yeah, I would certainly endorse what you said. An interesting comment that we found kind of along the process as well, when we were trying to figure out what to call this stuff that is blended and then given through a tube, the overwhelming response from parents was, it's food. It's not feed. Feed is what you provide to your horses or cows to eat. It's not formula either, because it doesn't come in a container. It's just food. And that I've started modeling that. And even for things that are commercially produced and given through a tube, I now call food instead of feed or formula.
That's really fascinating that the parents would be saying that. That's what I hear clinically. So that's super cool. Yeah. And important for the children to hear that it's time for them to have their food and what is in that food, and for them to maybe see what's happening with the blending and what is going into the blender.
We do have a question in the Q&A. I'm curious to learn about the tube weaning programs and how they may or may not be informed by concepts of serve and return, responsive feeding, etc. Let's see. Christina, Carrie, do you want to address that? And others who may want to chime in about tube weaning?
Absolutely. I'm not as closely involved in this one, but I do know that it is definitely informed by responsive feeding. That is the model that is being used. It's just in Calgary, we're just in a pilot of 10 patients right now, and using the responsive feeding approach. And I'm not sure exactly how it's going to play out, but we're excited to see what successes they have and what we can do from there.
I would really support that it is a behavioral based approach, and that the developmental factors and that serve and return are really very much a part of it. Is there anybody else who wants to speak to that?
It's Melissa. We've had a significant amount of feedback and interest in further discussions and education around tube weaning. So I guess just know that with the Calgary pilot, an extensive literature review was done by Sarah McKenna, and working through the available literature on the different weaning models in that ambulatory setting. And so I think, we hope that maybe once that pilot's completed and there's been time to digest the results and look at making larger recommendations, that hopefully that pilot can be presented and shared to the broader audience. So I definitely see that as being more to come. And then as well, we would be looking at the clinical practice guide information and seeing where maybe we need to make modifications or add content based on the results of that pilot. So definitely an up and coming area with more to share.
Looking back at the Q&A and moving for a moment back to home blended foods. Although I have great success with families using home blended food, I was frustrated that FSCD no longer funds like formula. Instead, they will only cover a high calorie diet, even though some kids required an entirely separate recipe than family foods because of multiple intolerances. I have one family that opted to just use complete instead due to the coverage issue. I would certainly agree with that. The home blended foods diet is expensive. I mean, you're using things like avocados and coconut oils and flax seeds and things that are not typically put in our everyday diets. And it's a very, very high quality diet for families who provide their children with the home blends. I think those children are getting the very best that there is in food. It is expensive though, and you're right, that is not covered specifically by FSCD, nor is it covered by the tax relief programs that exist. So that's certainly a consideration. What you mentioned, using Complete, is a similar option to doing home blends, and in fact can have some advantages in terms of the preparation time and transportability and that sort of thing. And so some families may use Complete for that reason, or interchange or trade off between the two depending on their circumstances.
I have a couple comments to add. One, I guess, specifically with FSCD in Calgary, we have had success with families actually requesting and using some of their respite time for extra time to do the blends. So they don't get the coverage under the formula component, but they do get hours and time to have assistance with doing blends, especially if they're doing batches. I guess the other comment, and not to disagree with Sharon about it can be more expensive, we also have families that blend what they're feeding their other children on the plate, and they add their liquid in the blender. So it doesn't have to be. I think that all comes down to choice. So, and then just a third comment about that is, you know, if they're complete and they have coverage for that, like Carrie said, there's always a benefit to a combination. So maybe they do a little bit of what they're feeding the rest of the family and they add some complete to it. So I think there's a lot, like there's a wide range of what you can do with home blend and to make it work for each individual family.
Thank you. Moving on to another question in the Q&A. We are seeing more families in Calgary specifically accessing private myofunctional therapy, often seemingly promoted through dental offices. Any thoughts on the efficacy of this in the context of feeding? I have to admit, I don't know what myofunctional therapy is, and so I will defer to any of those on the panel who could answer that.
At our clinic, we've had a few sessions with a myofunctional therapist, a very experienced gal who actually works in Calgary mostly and then just comes up to Edmonton a bit. And so she's been giving us some continuing education about what her field of practice does. She's a dental hygienist who's got extra training in this area. And what she's described to us is just a variety of different exercises that she supports young children, older children, adults to do to strengthen the muscles of the jaw, the mouth, the tongue, the lips, to improve function. That's kind of it in a nutshell. And she's doing intervention for eating challenges as well as not so much speech. We didn't talk about that, but eating and sleeping challenges. So, and I don't know the literature on this topic at all, but we did explore that and talk to her just so that we knew a bit more about what she and other myofunctional therapists do. It sounded like physio for the oral cavity. Anyone else jump in on this topic?
You're opening up a nice can of worms there. Really nice description, Dr. Hapshin. Just to speak to that from the perspective of our CPG, when we're looking at feeding difficulties, there certainly can be an element of an oral functional difference. So oral myofunctional being looking at the alignment of the jaw, the alignment of the teeth, where the tongue is positioned in the mouth, and the strength of the different organs within the mouth, and how that then has an impact on feeding. The research on this is really still out, although this is definitely a growing area, and a lot of people are seeking out this kind of intervention. We do recognize that one of the important things about looking for improvement in actual eating, feeding, swallowing skills requires that we involve skills that use eating, feeding, and swallowing. So isolated strength-based or movement-based activities do not always transfer. So this whole oral motor skills development, I remember when I started in this field 25 years ago, we had blowing bubbles and sticking the tongue out to push it to try to strengthen the tongue or try to wake up the mouth. And what we found is that those oral motor skills, practicing those did not have an impact on speech or feeding and swallowing. So within that context, when we're working on strengthening range of motion and looking at coordination of movements with those kinds of exercises, we need to look at how we can move those into feeding. So there's definitely a lot of really great research out there on using breaking down tasks into simplified tasks that are progressive so that we can work on things like lateralizing the tongue and holding the food on the chewing surfaces and progressing through textures. And so there is an element of that in the oral myofunctional therapy as well. The other thing that we've seen, but most of the research that I've seen shows that we've seen movement in the alignment of the jaw and the movement of the tongue in isolated movements. I have not seen good evidence to show that it has had a significant impact in improving eating, feeding, or swallowing skills yet.
Thank you so much for that, Julia. And I do see that Melissa has put something in the chat, that there are some oral motor exercise resources posted to the community of practice that you can check out.
Julia, can you just expand on that, just with regard to practicing and having that practice guided by a therapist of moving food in the mouth and accepting different textures? So I just want to clarify, are you saying that actual guided practice, there's no evidence to show that that helps the chewing, swallowing?
Without using foods, unless you're working specifically on breaking down the skills that are going to have the impact on that specific deficit that you have. So if you have a child who's not yet able to lateralize their tongue, and that range of motion is something that we certainly see tongue ties and other things having an impact on, what aspects are holding that child back? So is it an anatomical difference? Is it a strength-based difference? Is it a range of motion? And if it is something that can move with practice, that we've seen with lots of these motor planning practice, we can see improvement of lateralization to hold the food on the chewing surfaces to then be able to work through more challenging solid textures from the mashing that we see and just swallowing foods whole with the tongue. So that kind of practice, we definitely see an impact, breaking it down. And as Melissa mentioned, there are lots of resources to look at using dissolvable solids and then progressing through textures. And that's something with the involvement of a trained feeding therapist that we can see good progress with. Did that clarify it for you?
Yeah, absolutely. So what you're saying is that to develop motor plans and motor skills for eating, you need to do it while eating, because that's how the brain learns. Just doing generic myofunctional therapy there's no evidence that helps. It has to be very specific to the process of managing food in the mouth.
Exactly.
Melissa has also put into the chat, we have a parent handout that Julia's group developed to support biting and chewing, posted to the PEAS website.
So one of the caveats that we've had in this, we've had lots of requests for oral motor skills in handouts and, a play-by-play of how do I do this? People really struggle with helping their children to develop their eating, feeding, and swallowing skills. But in isolation, to give a parent a handout like that, we really, as a group, felt that it was irresponsible because we are putting in their hands. We're expecting them to break down the task to understand where the deficit is and find the specific task that their child needs at that moment and then move forward with that. And really, that's our job. So really important that we have a specialized pediatric feeding therapist working with the family to help guide them in those. When we are looking at specific tasks like learning to bite off pieces and learning to chew, we can break that one task down into some things that are fairly universal. So those are the ones that we chose to target in terms of a handout. I'd be interested to hear from people as we move forward whether there are other areas that they're finding. Another one that we developed is the cup drinking, because it can also be broken down into small pieces that we can work through, with absolutely the caveat that if we're running into any kind of difficulties with controlling the bolus and swallowing, that it's really important that we get help.
Well, all of this talk about feeding is making me hungry, and we are coming up to the 12 o'clock mark. We'll end here. I want to thank all of the panelists for passing along the information that they did in the presentation and for answering questions. And I want to thank all of you who have participated. Again, I remind you that you can reach out to us at peas.project@ahs.ca and request once again, if you can, to fill out the evaluation. So thank you, everybody. The survey link is now in your chat, and so that is available for you. Thank you, everybody, and have a great day and great long weekend ahead.
And thank you, Dr. Spicer, for assisting with moderation of the Q&A percolator time. I appreciate it. Take care, everyone.